Well, today I am absolutely delighted to welcome some of my colleagues here today who are joining us, who have a vast array of knowledge in this specific area. So first of all, I'd like to welcome Mike Large. Mike is a PhD from Baylor College of Medicine, where he focused on the intersection of progesterone and growth factor signaling and their role on endometrial receptivity. As he was finishing his work there, he was snapped up by Genesis Genetics, where Mark Hughes was the CEO of Genesis Genetics, and he opened our research facility in Houston. Mike rapidly became our go-to guy for all things technical, especially with next generation sequencing and applying that to pre-implantation genetic testing. So we're really delighted to have Mike here today. Mike went on to run one of our testing labs in LA and is now the Senior Director of Genomics Research and Development in Houston. Thanks for joining us, Mike, and welcome. Next off, I am going to introduce somebody who really shouldn't need any introduction if you're here to listen to a pre-implantation genetic testing panel, and that is Professor Mark Hughes. Mark graduated in biology and chemistry at St. John's Universities, followed by a master's in biophysics at Stanford, a PhD in molecular biochemistry at the University of Arizona Medical Center, and then he went to Houston to work at Baylor College of Medicine, doing a postdoc with the famous geneticist Bert O'Malley, where his work was published in Science and Nature. He continued this by getting a MD at Baylor, and then went on to do his clinical subspecialty at his favorite basketball team, Duke University. And then he returned to Baylor to form the Genetics Institute led by Tom Caskey and Art Baudet. When he was there, he realized that he could get molecular information from single cells that could be used for diagnostics. And this led to a collaboration now that is very famous with Professor Lord Winston and Alan Handyside at the Hammersmith Hospital and UCL in London, where they were able to do the first pre-implantation genetic testing, PGD, or as we now call it PGTM case, and opened up a whole new field of medicine, which is an amazing thing to do. So we're really looking forward to Mark's input on this. And lastly, I'm also delighted to welcome my colleague, Christine McWilliams. So Christine McWilliams serves as the medical director of Cooper Genomics. She's been instrumental in the path and career and the direction of our genomics division, and works with the cross-functional teams. She also, which I think will be great for this discussion, manages our genetic counseling program, and really importantly, ensuring that clinicians and patients are equipped with the correct genomic information to infer their choices and transfer decisions. She's worked in the PGT field since 2013. Her particular expertise, and I'm well aware of this because she's a go-to expert for it, is in PGTM2. She obtained her MD and PhD degrees at the University of Penn Medical School, and her doctorate in the field of human genetics and epigenetics. Okay, so this particular Ask the Experts panel is centered around the subject of emerging evidence, improved clinical outcomes with the PGTai 2.0 platform. This refers to our webinars that we ran yesterday. Hopefully you might have been able to catch them. And we'll be talking in general some of the questions that come up. So we've had some questions already submitted that come up in relation to that, and general PGT questions that we'll be able to answer as we go through. So really, without any further ado, I think we should start going through some of the questions and see what there are. So I think the first question would go to the general panel, because it's quite a general question and quite a difficult question to answer. So what's the percentage of false negatives that we see in PGTA? I think it applies to PGTA. PGTM is something that I think is a different subject. And I'd like to throw it open to maybe Mike. Mike, would you like to try and take this one on?
Thanks for prefacing that it's not an easy question to answer. And certainly, I think one of the major challenges, of course, is that we're working with a biopsy, and what we see in one biopsy may not necessarily reflect other cells. And so, for example, in the case of mosaicism, we could have a 5-cell biopsy and not have detected any aneuploid cells. And I guess maybe we should clarify, or I'll at least talk about how I see false negative and what that actually means. And so in any sort of testing environment, you often are testing for the presence of the pathological state. And so here would be aneuploidy would be essentially what we're testing for. And a false negative would be we did not detect aneuploidy when it was present. And so from that perspective, if it's certainly possible that you do a biopsy and you get euploid cells, and in fact, there are aneuploid cells somewhere else. And so you can look at that as either a limitation of biopsy, which exists in all fields of medicine, cancer, biology, et cetera, or you can look at it from, does your technology have the sensitivity needed to detect that? When we look at some indicators of the extent to which false negatives occur, one of the most prominent places that we can look is really what happens when there are adverse outcomes with what we suspect to be a euploid embryo. And so a number of the groups that we partner with will often do product of conception testing and any losses, for example. And of course, if they were ever to find anything, they let us know about that. And from the vast majority of people that I've spoken to, they always come back euploid. So that's a pretty good sign that false negatives are low. I think we've done a number of rebiopsy type studies looking to understand and explore the incidence of mosaicism. And again, it's something that it certainly can happen, that the first biopsy appears to be a clean euploid, and through multiple other biopsies of many embryos, we do on occasion find that there were aneuploid cells in the embryo, but again, it's pretty rare. I know I don't have, unfortunately, an exact statistical number of how often that happens, but for some of those indicators indicate that it's pretty uncommon.
Thanks, Mike. And Christine, this must be a question that comes up quite frequently with genetic counseling. What's the number that we give to patients in terms of the described accuracy of the testing? And how does that sort of, in your experience, vary? I know that just apocryphally, it's described that there's quite often discrepancies between NIPT results, and how does that apply to what our experiences of the accuracy of PGTai ourselves?
Yes, and thanks for the question. Obviously, accuracy of the testing we perform is a big part of every genetic counseling session that we hold for patients. We typically, when we are, and we do get the question regarding, quoted false negative, false positive, positive predictive value, negative predictive value. We tend to focus again on the quoted accuracy that we have for our test, 98% or greater, but highlight really the challenges of getting the values that those other values, and the importance of sharing outcome data in order to achieve that. So we additionally really appreciate groups such as NYU sharing outcomes that they've been able to achieve with our testing, but also we always give the option and ask for our patients even to share their own outcomes with us. Not only are their successes, learning about their successes so appreciated, and help us keep keep going in this field. But when they're not successful, we really do try to learn from that to make our tests stronger.
Thanks. Christine talks, sorry, had one other point on that. I think Christine has some interesting perspectives as well in terms of making our tests stronger. I think it's difficult to talk about the false negative rate of PGTai or the sensitivity of PGTai because it largely depends on the technology you're using to look at things. And I think, Mark can speak up to one of his metaphors about sensitivity, but if you are looking very briefly or with limited data, it's certainly easier to miss things. And that's why we've taken an approach to continually add data to the way we look at things to try to maximize that sensitivity. And so there's a trade-off, of course, but the more data elements you look at, the better the redundancy you have, the better you're able to distinguish signal from noise, the better able you are to detect whether or not any abnormalities are present.
Oh, you need to unmute, Mark. Welcome to 2020. It is the term of 2020. Unmute.
And of course, we're using machine learning, artificial intelligence to analyze these large collections of data on every embryo biopsy. It isn't just a few data points anymore on a chromosome. It's upwards of 4 million on an embryo biopsy, and you need computers and machine learning to do that. And that goes to what both Christine and Mike have just said, which is we need outcome data on all these pregnancies in order to keep teaching. It isn't machine learning if you're not teaching and continuing to input larger and larger numbers of outcomes. So that's why we enjoy and actually really request that clinics feedback their outcome data. Most laboratories, pathology laboratories, whatever, they always complain that they put out the data and then they don't hear back. And that doesn't help make the technologies better.
Thanks, Mark. I think we all agree on that. Improvement is feedback. So let me just say we have quite a lot of participants who are very shy. So if you have a question, nobody else sees your question. It can be the best question we've ever seen ever, or it can be something that is, fairly straightforward. But don't feel shy to put your question across, and we'll try to get through to it. So the next question is one that came through beforehand as well, and it's a question that I think is really interesting, and it's quite a difficult one for a lot of people to grasp. And it's a kind of, there's apples and oranges, but then there's lots of different types of apples. So we use snips, and other platforms use snips. So, where is our platform different, and how does that then apply to the test? And then how do we think that applies to the patient, to the result? And yeah, please feel free to chip in, Mark, Christine, Mike, on that one.
So I guess that's mostly targeted to me, or I'll start off on that front. And so certainly, and I think it's important that we distinguish PGTai and the SNPs we use there from PGTM and the SNPs we use there, because those are currently different platforms. Really, when you look at the way SNPs have traditionally been approached by the field, it's through SNP array. And so whatever the array technology being utilized, humans curate which SNPs they think want represented on that SNP array. And many of that curation has been done sometimes over a decade ago now, and many of the elements that were initially believed to be SNPs are in fact no longer SNPs. And so I think that's one of the major differences between how we're using them in sequencing versus a SNP array is there's a conscious decision, and by all means, many of the SNPs chosen are in fact still good SNPs. But there's a decision and a fixed representation of the number of SNPs and which SNPs are present on a SNP array versus in the sequencing approach, really any nucleotide changes, any SNPs, even if they're not well characterized. And so a little bit esoteric SNPs are a type of single nucleotide variant that's well characterized. We know it occurs in at least 1% of the population. It's been studied in different ways. Whereas in sequencing, we take our best approach to look at as much of the genome as possible with all the data points Mark talked about. And in that perspective, we're actually able to get more data elements into the platform. On a SNP array, it's a little bit easier. You're ultimately trying to decipher in sort of a binomial fashion. Do I have this allele or that allele? And so in some ways that can offer a little bit of clarity, but it's really a concept of a genotyping level of accuracy on a smaller number of curated SNPs versus looking at a whole genome wide or every SNP that comes across in the sequencing platform on your region of interest.
Thanks, Mike. And in practical terms, how does that how do those SNPs actually impact what your test can detect?
Yes, that's another good point. So, I mean, first and foremost, we've spent a lot of time really trying to develop the best assessment for copy number. So Mark hit on that we're using millions of data points. We're using machine learning and AI, and we're trying to take as many sequence reads or little DNA sentences and normalize to the genome and get accurate copy counting. We then added the SNPs on top of that because I talked about those SNP ratios. Which SNPs do you have? In the presence of aneuploidy, and where you may have a heterozygous SNP, in other words, there's two different types of nucleotides on the two copies of DNA we have. If you lose one copy, that's known as a loss of heterozygosity. So you lose essentially all of your heterozygous SNPs, and that can be informative and confirm that there's a loss of material. In contrast, when you have a gain of material, now you will have a 2-to-1 ratio in heterozygous loci. And that again, that quantitative difference is an independent mechanism to get a confirmation or rejection of any signal to noise issues and any deviations from the expected diploid presence. That helps us in regions of interest. It helps us calling any sort of antibodies, but it also helps us genome wide. And so in that same concept, one of the things that's enabled when we first launched our platform a year ago was the detection of female polyploidy and female triploidy. So historically, the way the sequencing-based approaches have been able to report out polyploidy in PGTai is really through a mathematical inference. And so I talked about those DNA sentences being normalized across the genome, and we basically count as many DNA sentences as we can, and we set the median to 2.0 copies. That's the way it used to be done. And in the case of male triploidy, you have 2 copies of one sex chromosome and one of the other, so 2 of X, 1 of Y, or 1 of X and 2 of Y. And in the diploid setting, we expect that 1-to-1 ratio, but it's really that 2-to-1 ratio that we can make mathematical inference that in fact, when we see that perfect ratio, we can infer there's male triploidy. However, in the absence of male triploidy, so in female triploidy, all you have is X chromosomes for the sex chromosomes. And so you can't do ratiometric inference there. It was only once we had the SNPs to look genome wide that we could actually detect that there was in fact female triploidy there, which in blastocyst biopsies, we're seeing close to 1% occurrence. And these, of course, can result in adverse outcomes, failure to implant, miscarriage, molar pregnancies, and those sorts of things. And so being able to add those on, I think has made a big impact.
Thanks, Mike. Well, I'm glad to see that after my little request for people not to be shy, we do have quite a number of questions coming in. Although I have one question that I want to ask that came in beforehand. And again, it's to everybody, and it's probably one of the hottest topics in PGTai, and probably one of the most, often debated. How can 5-cell biopsy screening can extrapolate to give you a result from a mosaic embryo? So maybe, that's a bit of a how long is a piece of string question, but give us your best shot. Mark, you look like you want to answer that, but Christine, Mike, please chip in.
Oh yeah, I really want to answer that. Okay. So because we have a large audience and some of you don't have a lot of genetic genomic experience, let me just sort of make a couple of basic comments about this hot area that everybody's percolating about this mosaicism business. And then we can get down into some more nitty-gritty about it. That's a good question, actually. But let's go back and remind ourselves of a couple of things. First of all, we've known that perfectly normal fetuses have had mosaicism way back in the 1980s when chorion-villus sampling started to be done, and you'd find a mosaic in the CVS sample of that fetus, and then you would repeat that test a few weeks later when there was amniotic fluid, and you wouldn't find the mosaicism anymore. And so the question was, well, was it real in the CVS, and what happened to it? And is it in the fetus, and what does it mean? And we learned that the amnio was a better predictor of what the fetus had than the CVS was, which of course was a biopsy of the placenta as it was developing along the uterine wall. So we've known that mosaicism has been around a long time, and many of you know famous Alan Handyside, a really well-known embryologist and geneticist, and he said once that we've been transferring mosaic embryos ever since Louise Brown, and we just didn't know it. And that's absolutely right. And just like you get more information out of a CAT scan than you do out of a chest x-ray, and you get more out of an MRI than you do out of a CAT scan, the technology gets better, you see more, and then you ask yourself, what is that new information teaching us? And so once we finally had technologies, not like fish, where you only had one data point per chromosome and you couldn't even look at all the chromosomes, and not even a microarray where you didn't have the amount of data necessary to pick up mosaicism. With whole genome sequencing, you can see it. And of course, that isn't a surprise if you look back, but it was a puzzling concern when we first started noticing it in biopsied samples. What does it mean? How important is it? Is it an artifact of some kind? What's going on? Well, we know it's not an artifact. We just have a Hubble telescope now looking at the stars rather than a pair of binoculars, and we're seeing mosaicism that we couldn't see before. So it's very easy to have a laboratory that doesn't have any mosaicism because they're using a test that's below the sensitivity of seeing it. But you also don't want to have such a sensitive test that you're seeing things that are not important, and all you're doing is creating anxiety and stress amongst the whole IVF group. My God, what does this mean? And or amongst the couple, which is the most important. You've now told them their embryo isn't perfect, and now they're all nervous. Okay, so let's kind of get to the question. First of all, remember that this whole technology was really developed for testing for aneuploidy, where there was an error in meiosis. So in the process of making the egg or the sperm, you had a early sister chromatid separation, or you had non-disjunction, something happened and the wrong number of chromosomes went to one daughter cell versus the other. So now you had a pair of cells, two daughter cells, in which one had an extra chromosome because the chromosome went the wrong way, and the other one had an opposite. So you actually have the reciprocal, you have a trisomic cell, and you have a monosomic cell. And now sometimes those cells will die and sometimes they won't. They'll continue to divide away. And as they do, and you go from a, say, a day 3 8-cell embryo, you go to a blastocyst, you now have patches of these abnormal cells that are in that sample. The second thing to remember is that a biopsy in any kind of medicine, whether you're biopsying a mass in the abdomen or something, or you're biopsying an embryo, it's just a sampling. So you could biopsy a tumor and you can see no abnormal cells, but that doesn't mean on the other side of that mass there isn't a malignancy. So the test is only as good as the biopsy. But unless you biopsy the entire mass or you biopsy every cell of the blastocyst, and then you don't have a blastocyst anymore, you don't really know. So you're sampling as best you can do. And if you sample and you happen to hit one of those patches, say on the trophectoderm that has an extra chromosome, then you'll report back a mosaicism in, say, the 5 or 8 cells that you biopsied. You might have 1 or 2 or 3 that are mosaic, that are aneuploid, but in a sea of normal cells, and so you have a mosaic biopsy. So some people say, well, then just do another biopsy. Well, nowadays with vitrification, you've already frozen the embryos, but you could thaw it and do another one, but it's not a smart idea because you're not likely to see it again. And that goes right to the heart of the question that was asked, which is how do you extrapolate from the biopsy to the whole embryo? And you really can't accurately do that. All you can say is that the earlier the abnormality happens in embryo development, the higher the percentage of the mosaicism you'll see because you've got more daughter cells that are coming from the one abnormal. Whereas if it happened, you've already got a blastocyst, you'll have very low level mosaicism. You might not even see it in your biopsy. What we know for sure is that it's better not to transfer a mosaic embryo if you have euploid ones. That's the first take-home message. And the second is, if it's the only embryo you have, they will go on and make normal babies just like CVSs. But we don't know where those cells are. Are they only in the trophectoderm where the biopsy was done, or did the abnormality happen early enough in development that those cells are now in the ICM as well? And if they're there, well, then that could be a problem. And it depends on what chromosome it is. It depends on what percentage of the cells there are, but we do know that there's a higher miscarriage rate and there is a lower chance of implantation if you transfer a mosaic. That doesn't mean you throw it away, but you have to have a serious counseling session with the couple about the fact that that embryo could very well make a healthy baby, but we better monitor it all along the way. We might have a miscarriage, so we should watch. But in a very expensive, emotionally expensive, psychologically expensive, financially expensive IVF cycle, if you want to optimize the chance for that couple to walk home with a smile on their face and actually have a live-born, you have to weigh all of those kind of considerations. Not really any different from, well, you know, we have a Gardner scale embryo here that isn't very great, but it's the best one you've got. Let's put it back and hope. So this is the art of medicine. There's a lot of science in it, but you do a lot of art in an IVF center, and the genetics is no different. It's not a binary answer sometimes, and mosaicism is one example of where it kind of gives us fits and starts.
If I were to add one other thought on how well does a biopsy extrapolate to the embryo, I think there's sort of two conversations. One is qualitative extrapolation versus quantitative extrapolation. And so certainly in that 5-cell biopsy, if we saw 2 out of 5 cells had abnormalities to them, and we would consider that a 40% aneuploidy or 40% mosaic in that biopsy. That does not mean directly that in the rest of the embryo, all embryos are 40% abnormal and 60%, or all cells are 40% abnormal, 60% are normal. And so in terms of exact mathematical extrapolation, I think there is a nonlinear relationship there. Qualitatively speaking, though, if we identify abnormal cells in a biopsy, that is informative. And we know that, okay, this embryo at this stage has abnormal cells and it has a lower probability of success. And maybe it's still considered a good probability of success, especially depending on how many other cycles or other euploids or other circumstances, very patient-specific outcomes. But it simply says that we have identified abnormal cells, and this embryo, remember PGTai was once called PGS, screening, and the objective is to try to rank and prioritize which embryos should you put back first to minimize your negative outcomes and maximize your probability of success in the shortest amount of time possible. And so in that regard, if you do detect abnormal cells in the biopsy, it is informative. That said, even though I've sort of really made the case that quantitative extrapolation, there's a disconnect there, I think it's only natural that if you have multiple embryos, and some of them we've identified only a small number of abnormal cells in the biopsy, but in another embryo, we identified most of those cells to be abnormal, that feels like information that can be useful. I think we talked a lot about outcomes already, and so eventually we will find out if the exact percentage of abnormal cells in the biopsy is actually predictive of outcome. But again, going back to that concept of ranking the embryos, some folks do find that information helpful in their prioritization.
Thanks, Mike. Fascinating subject. And in fact, we could probably spend the entire time talking just about that subject. So I do have some other questions that we'll move on to a little bit quicker. And I'm delighted to see that some of our attendees have actually asked questions, and we'll try to get through to some of them. I would also say to you, if you have a question, please post it. That is what it's meant to be, interactive, and we'd be delighted to ask you questions. So 2 questions that I think maybe Christine, first of all, is one that you probably get being on running some of the GCs and some of the sort of patient-facing side and the clinician-facing side is, so does the physician have to decide between running SNPs or NGS for PGTai? I think it's something that is sometimes a little bit misunderstood about our platform. Christine.
Yes, and with our platform, no, a decision is not necessary there. Our PGTai 2.0 automatically includes both methods to get to these clinical outcomes that that we've just been speaking about.
So the other question that I have is about karyotyping and whether the question is a little came through, and well, we've been discussing exactly quite what it meant. We think what it means is, should you karyotype patients before they go into IVF, or is it suitable to do it by PGTai? I will completely put my cards on the table by prefacing this by saying literally 10 minutes before this started, I saw a beautiful example of a case where we'd seen a completely cryptic translocation that we'd picked up in using PGTai 2.0. Christine.
Mm-hmm. Yeah, and that's a great question. I would say that really it depends on the family's own medical history. And whether entering into IVF, what is their story? Why are they there? Are they a family that, for example, has experienced a number of miscarriages, early miscarriages? If so, then it might be wise to, even before considering PGTai, have that karyotype analysis performed. Importantly, not all families with identified, say, reciprocal translocations, not all of those families will that identified structural rearrangement be amenable to PGTai. PGTai has improved throughout the years tremendously to be able to identify imbalances resulting from translocations, now with the the same resolution as in many cases diagnostic level tests. However, not all imbalances can be detected by PGTai. And in fact, if a family is referred to us for PGT-SR, which does use that same PGTai 2.0 technology, each one of those cases is individually evaluated before accepting the case to be absolutely certain that our technology will detect the predicted imbalances for that family. So always, if the history suggests that there may be a structural rearrangement within the family, it is appropriate to get karyotype analysis done prior to PGTai. That being said, as Tony just mentioned, we do from time to time pick these up in families that were not aware of this before they had PGTai testing done. We look very closely for any trends or recurrent aneuploidies that we're seeing between embryo biopsies to see if it's possible that there is a pattern there that could be suggested of a structural rearrangement. And if so, we do communicate that back to our clients with recommendation that a karyotype would be reasonable. Of course, our genetic counselors are always ready to talk to these families and walk them through these results. And in many instances, we have found that if karyotype analysis is performed, it does come back and confirm what we detected with the PGTai technology.
Thanks, Christine. Really clear. In fact, actually, I remember a case when we got the data back, and we had both parents were carriers of a translocation. Amazing case. So, Mike, question for you, and it kind of relates a little bit back to the fantastic webinar that you did yesterday, and I would really recommend anybody that didn't catch that webinar and Mike's presentation yesterday that they should go to our website and catch that. And it's from one of our attendees. Let me just also say, please put your questions in. We'll try to get to them. And it says, the improvements in your PGTai platform, are they due to how the test was developed on embryo data, do you think, the AI, or the addition of snips? And this comes to the great presentation of Julia Boldo-Licciardi from NYU yesterday, which showed an improvement in outcomes with the platform. It's quite a difficult question. Where do you think those improvements have come from in the technical aspects? Over to you, Mike.
I think I'm first reminded of back to many years ago when I was still in school and you were doing a multiple choice question, and you always guess all of the above is your most likely answer to the question. And so we certainly have seen improvements at each stage of our technological innovation. And so I think really the use of real world biopsies to build the algorithm to test for what we actually get and see certainly went a really long way and helped us better diminish noise and further differentiate our signal. And I think that to some extent that certainly helped with some specificity improvements and some increased euploid classifications. We then also significantly increased our sequencing capacity. Essentially 10x the data went into the system. And so I think with that, I talked a little bit earlier, one of the first questions was about false negatives and sensitivity. Well, the more data points you have to remember our genome is 3 billion base pairs long. And so the better you are able to sample that and look at different regions of the genome, the more accurate your predictions and testing are going to be. And so in that regard, adding more data, getting more sophisticated in our sequencing strategy, going to paired end sequencing, being able to better access some of the difficult regions of chromatin, I think that probably helped us pick up some sensitivity and being able to detect some potential issues. And then I already hit on how we've utilized SNPs to confirm or reject any potential calls that are coming up. And so really, I think we're striving to maximize both sensitivity and specificity. And so really, we're hoping to see the highest euploid rates possible with the lowest adverse outcomes and miscall rates possible. And as you mentioned, I thought Julia showed some really compelling data from, unfortunately, pregnancy takes a long time. So we have a lot of biopsy data. We know classification rates and how those change. Some of the clinical outcomes are a little bit slower to come on the back end, but in her center, what they've seen so far is an increase in euploid classifications and almost a 50% reduction in biochemical losses, some of the adverse outcomes. And so I think those two pieces of evidence really underscore that we're working to increase accuracy, and it's having an impact.
Thanks, Mike. Really nice, comprehensive answer. So I have a question here, I think, for Mark and Christine. Another pretty tricky question for you, and it's, should PGTai be routine for art cases? Over to Mark, Christine, please feel free.
Want me to go first?
Of course.
Well, As a physician, I mean, my view is that nothing should be routine, and that any testing that you order on a patient needs to be customized to the uniqueness of the setting in which you're seeing them. And that brings into play all kinds of things like how old are they? And is this their only opportunity to go through IVF and they won't be able to go through any more cycles, and all kinds of things like that, which would all factor into this large polynomial equation about what testing do you do for them. My sense is that as they get older, it makes more sense because even if all the embryos are aneuploid and you can't do a transfer, you've saved this couple a lot of anticipation that the embryo you transferred that was untested it actually is going to make a baby, when for most of these chromosome aneuploidies, they don't make a baby. So you've given them some hope that is really not fundamental, real. And then unfortunately, some of them will go on and get pregnant and then have a miscarriage. And now you've lost a significant amount of time. So time to pregnancy for that couple is now quite delayed before they can go through another IVF cycle with you. So it's better to know and not transfer an aneuploid than it is to transfer it and then wait and have them have a loss, and then wait for her cycle to get back to normal so that you could actually do another cycle in the IVF clinic. I think it gets more complicated when the patients are younger. And I think it depends on where you live and how much that IVF cycle actually costs, and the attitude of the couple about this whole process. The younger they are, the less likely you're going to find an abnormality. But don't forget, if they're 34 years old, fully half of the embryos are aneuploid. We don't do very well as human beings in making euploid embryos, mostly because we postpone our reproductive time for societal reasons to way past when we're capable of getting pregnant, when we're 13 or 14 years old. And so as those meiosis events get aged, we have a higher rate of having abnormalities. So I guess in the bottom line is it's useful in all settings. If as sequencing becomes less and less expensive, and it becomes less and less expensive to do these kinds of tests, I would hope that someday everybody will want to have it, have the test. But I don't think it would be right for me to say everybody needs to have it. I think it's better to have it. But Christine, you'll probably argue with me on this.
Not necessarily. I think, Mark, it gets back to what you said earlier today about the art of medicine. Where guidelines are really to represent what physicians should recommend to patients. Guidelines don't necessarily and shouldn't prevent physicians from having conversations with patients about their own specific goals. Obviously, I think, we know that there's a shared goal within IVF that people want a baby. That's the goal. That's a shared goal. However, there's definitely different stories of what brought patients to IVF clinics and how far they're able to travel to achieve that goal. And so, I think there's, quite a bit of evidence coming out that shows that PGTai is beneficial in critical outcomes such as live birth rate, as well as miscarriage reduction in older patients. But even for younger patients, as you mentioned, aneuploidy is still quite common, even in younger patients. We have seen, and it was actually just presented at ASRM, that even within cycles that utilize donor eggs, aneuploidy is still present, and maybe present more commonly than you would think. And so I do think that at least that conversation that aneuploidy is present at any age, is a risk at any age, should be had with each patient. And then, in the discussion of the goals for that patient. It could be, for example, that even a younger patient has experienced a couple of miscarriages and is desperate to avoid that outcome again. And we know that PGTai can prevent miscarriage for that patient. So in that instance, regardless of age, PGTai might be a good option.
I'm just the lab rat scientist here compared to the two physicians, but I think that last scenario really resonates with me personally. If you look at even the least sensitive technology and the best prognosis youngest patients, I think you're looking at least still 1 in 3 embryos can be aneuploid. And so it comes back to what is the reproductive goal of the patients that you're treating. And my wife and I suffered a pregnancy loss. We're under 35 age group. We're the good prognosis. Aneuploidy shouldn't be an issue. And I can tell you it's devastating. And I can't imagine if you've gone through that multiple times and say, there's a test where you have a 1 in 3 chance of a miscarriage, and if you do this test, you can avoid that. It certainly seems relevant and applicable to families like that. And so it really comes down to, as Christine hit on, we all have the shared goal of trying to have a healthy birth take home, but some different priorities, and even for younger patients, it can be very important to avoid those adverse outcomes.
Thanks, Mike. Yeah, I think the impact of miscarriage and the discussion of miscarriage is sometimes not front and center where I think it should be. I think Christine has been a long champion of the importance of discussing this and, how PGTai can affect this. So I have another couple of questions. So we had a question that came in beforehand, and it says, so far in the literature, I found one case report of transfer of a mosaic chromosome 2 that was confirmed prenatally and postnatally. I believe this publication is from Samara Kamaran's Memorial Hospital in Istanbul is the publication they're talking about. And it says, do you have any similar data? And I'm going to make the cardinal sin of sort of answering a question as a moderator. So please apologize this for me for now. I will tell you that in our lab in the UK, which has been running since 2013 doing PGTai, we've had one case of a POC that came back as mosaic, but it goes back to the accuracy of testing. And maybe Mike, Christine, Mark, you can chip in what your experience is of this, because we've been detecting mosaics for quite some time. Over to you guys.
I can say similarly from when I was more on the clinical testing side of things that once or twice a year we will certainly get some report back on product of conception, and very often if there is any aneuploid, it's in a mosaic context. So certainly it can happen, and I think Mark hit on how well can we extrapolate mosaic information, and do we have a calculus prediction of what will happen? And I think really it comes down to, as he hit on, when did the mitotic error occur? And I think we believe that most aneuploidies will eventually go through cell cycle checkpoints and corrections and apoptosis. When it comes down to the viability of the fetus or the embryo, I like to think of it as a critical mass scenario. And Mark hit on, if it's at the 4-cell stage, well, a large proportion of that embryo is going to have abnormal cells. But if it's at day 5, we're looking at maybe 128 cells or even later, you can have one of those adverse cell divisions that ultimately is selected against, but you still have a critical mass of healthy cells. Apoptosis, cell death, and reprogramming is a natural part of developmental biology. And so it really comes down to when, where, and what chromosomes are involved.
Thanks, Mike. Christine, did you
Sure,
want to?
Yeah, I can touch on this as well. This we have observed, I would say, a couple times. We did once have a result that came back from a euploid embryo that was tested by our older technology that we no longer utilize. And when we analyzed it, and we had obviously switched platforms to AI since that time, we did actually detect the mosaicism, whereas with AI, because of the improvements with baseline and the improvements with subjectivity, it was not clear or detected by the prior technology, but was detected by AI.
Thanks, Christine. So
that's an important point too, in that the profiles that you see on these tests are not always these beautiful things where anybody could tell you that this embryo has 2 copies of the chromosomes and it's diploid, it looks great. Sometimes the data is fairly noisy, and that can be potentially from the embryo, but often it's the clinic. We see noisier samples from some clinics than from others. We suspect that has something to do with the way they biopsy, the amount of laser energy they're using, the heat in the area that's probably fusing proteins to the DNA and Lord knows what all. And so there's a lot of confounding variables that make the data a little bit less than ideal to read. And this is where the computers are better than our biased subjective ascertainment of these results. And I think we do a much better job now. The data looks like we do a much better job of identifying what's noise, what really is noise, and what really is a low-level mosaic versus a moderate-level mosaic embryo sample.
thanks, Mark. Really, really good question and answer session there as well. So we have a question from the audience, and it's 2 parts, and I'll kind of split it between Mark and Christine, and maybe Christine and Mike. So it says, during counseling, if a patient receives only a high mosaic, and I think it meant aneuploid, result from their embryos, would you recommend the patients to go to oocyte donor? I presume you then are assuming that the aneuploid is maternal, which is another sort of question. So maybe Mike, you can answer how we can determine where the aneuploidies come from, and Christine, maybe you could answer a little bit about what, I know we counsel, we don't actually recommend fully, but maybe you can take that part. So maybe Mike, you can discuss the first part, and Christine the second part.
So I think that maybe what do we recommend in counseling could go first, but in terms of technology, certainly when we talk about moving on to oocyte donor, I think one thing that can be potentially, obviously you have to take into account the patient's circumstances, whether or not there's opportunities to go through another IVF cycle and those sorts of things before you would go to something like a donor recommendation. Many of our patients, it's very important that they have an opportunity for their own child. That said, we do have an option called PGTai 2.0 plus, and this is a circumstance in which we collect cheek brush DNA from the patient and the partner. And in that circumstance, any of the embryos that have aneuploidy, meiotic aneuploidy, full copy changes, we're able to, I talked about the SNP patterns earlier, we're able to use those SNP patterns and decipher which gamete failed to contribute or which gamete provided too much material here. And certainly I think those decisions on should we move to donor, that's where some of that information can be very important. I do want to stress that typically most patients don't have very many embryos. And if you observe, say, you had three embryos, 1 euploid and 2 of them were aneuploid, and in that circumstance, both of them were maternal. You always want to be careful when you over extrapolate small statistics in a single observation. So I think if you were to have multiple IVF cycles, and in all of those cycles, the vast majority of the aneuploidies were all derived from one of the parents, then you have added information that can help facilitate that discussion. I do want to also point out that we always talk about PGTai as focusing on mom, and advanced maternal age equals aneuploidy, and really in almost 90% of the case that's true. But what we've really come to find in the last few years is that's mostly true when we're talking about whole chromosome aneuploidy and meiotic heirs. There was a paper that came out last year that showed when we're talking about segmentals, deletions and duplications, smaller things that could be more about DNA damage, those are about twice as likely to be derived from the sperm. And so some of those circumstances, there's also been some associations with environmental exposures and other sorts of scenarios. And so I think it's a little bit of a challenge for me to just say default, it must be maternal factor. And also recognize that oocyte cycles are also have a burden and a cost associated with them, and so to make that assumption that it's automatically mom who loses her chance, and you go through all the investments to go through oocyte collection, and then it turns out if you had known all along it was male derived, then you've actually done the worst thing. And so in that regard, having information, always, I think the whole goal of PGT is to provide more information to make better choices. And certainly we can provide an opportunity to look at where the antibody is being derived from.
Yeah, and I can see that we're coming up short on time already here. But from the counseling perspective, I think one thing with mosaicism is we've actually not really seen that much of an age-related dependence on mosaicism relative to meiotic aneuploidy. So just because that's observed in one cycle, regardless of age, does not necessarily mean as predictive that it would be visualized again in a recurrent cycle. So I would say that with regards to high-level mosaics, in terms of counseling, whether or not that would be a good candidate for transfer, what our genetic counselors will do is walk the patient through the scenarios of, okay, this is mosaic, so we know it's in some cells, not in others. It's a high-level mosaic, so we know it has a higher likelihood to be in more cells, potentially in that inner cell mass. And let's talk about what that would mean. Let's make the assumption that this is in potentially all cells of the inner cell mass. What would the outcome for this? What would be the predicted outcome from this pregnancy? And we feel like that gives patients good information to take and discuss with their clinics about the transfer potential of that embryo. With regards to the origin, detecting origin of parental origin of mosaics can actually be quite technically challenging as well. It certainly could lend some information, but again, may not be predictive of what they would anticipate to see in the next cycle. So we would really defer the question of moving on to donor eggs, back again to the clinic. And what is more predictive of the next cycle is how many embryos that patient did have for biopsy in this cycle. If there's concern about achieving a good number of embryos of sufficient quality to biopsy, then that might be a reasonable conversation.
Thanks very much, Christine. And I just want to say that you start off these panel sessions thinking, will we have enough thing to talk about for an hour? And we usually get to the end trying to cram in answers because we've discussed so much. So for me, it's absolutely fascinating. It's great to have you here on this panel. Your expertise is invaluable, and I just want to thank you for the time. Thank you for all the attendees, for the questions that came through, and we got through a hell of a lot. Thank you very much.